Good afternoon, everyone. I'm Sarah Brewer, Executive Director of AdPERT, and I want to thank you for joining us today. It goes without saying that much has changed since we were last together 4 months ago. We've all been touched by COVID in some way. With a brother that's serving on the front line as a pulmonologist, I've worked through the emotions and realities that provides. Many of you have had the virus. Many of you have cared for a family member with the virus. You've helped a lot. You've lost a friend or a loved one. You've supported our medical teams, your residents, and helped those in clinical psychiatric settings. For you, I say thank you. Thank you for continuing to persevere through all of this, both personally and professionally. Today, we touch on a topic that has raised its ugly head in the last few months: racism. I can't succinctly capture thoughts and feelings about this. What I will say is the board and I have been and will continue to focus on ways to combat racism. We've published a statement many of you have seen. We've posted resources to our website, which we hope that you review and also contribute to. And we will be working with a consultant to explore the systematic racism that may exist within our own walls. Among other solutions, we are starting today with a virtual workshop to help us continue on this journey. Before we begin, I want to offer a few housekeeping items. Everyone is now muted, so we don't get to hear the vacuum cleaners and the dogs in the background. We will have breakout sessions today. There will be 2 of them. When that happens, please don't be alarmed if there's a slight delay. It depends on your Wi-Fi, it depends on a number of different factors, but sometimes moving in and out of a breakout room can cause a delay. Please don't be surprised. Please don't log off and try to log back on. Just wait patiently for that to happen. You will also notice that when we go to a breakout room, there should be a little button that appears on your screen that says join. And when you click on that, it moves you more quickly from the plenary session we're in right now into your breakout room. If you have questions, we ask that you put them in the chat and we'll do our best to address them as we go on. And please note that this is being recorded except for the breakouts. Above all, please be patient with us. This is our first virtual workshop and we are extremely grateful to Sarah, Michael, and Adrian for taking on this task with us and being our guinea pigs. To introduce the speakers, our lead today is Sarah Mohiuddin. She is the Child and Adolescent Training Director at the University of Michigan. And she is joined by her colleagues, Adrian Adams, who is the Child and Adolescent Training Director at Rush University Medical Center in Chicago, also our chair of AdPERT's Diversity and Inclusion Committee, and Michael Gibson, the Adult Training Director at the University of Michigan. Without further ado, please go right ahead.
Hi, everyone. This is Sarah Mohiuddin. Thanks for that introduction, Sarah. So we had the opportunity, Michael, Adrian, and I, to present this workshop at AdPERT the last time that we were all together in March in Texas. We had a lot of great feedback about that talk, and as Sarah was mentioning, everything has changed since that time. And one of the big issues that has come to the forefront was everything that happened after multiple ongoing deaths of Black Americans, as well as an increased awareness and understanding of racial and ethnic inequities that are occurring throughout our society, as well as looking within our organizations. And with that, we were asked to readdress some of the issues that we had discussed when we all met together in March. So my hope today with all of us is that we'll be presenting some cases that all of us have been a part of, and then help give you guys a chance to share some of those of your own as well through the context of the breakout groups, and then talk through solutions and institutional, programmatic, and faculty level trainings and changes that could potentially be helpful in supporting your trainees through what we know is a common experience, and that is the experience of discrimination, harassment, and mistreatment by patients. So with that, I'll go ahead and share screen to begin our presentation. Can you guys all see that? Is this your screen? Okay, great. All right, so today we'll be talking about the hidden factor in trainee wellness and how to support trainees who experience patient aggression, discrimination, and harassment. So our goal for today is to cover a number of different things. So the first is we'll be going through a number of different cases that some of us have experienced and have worked through. Then we'll talk through the prevalence of harassment, intimidation, and mistreatment toward trainees and what we know about that so far in the scientific literature. We'll talk through some definitions so that everybody is on the same page about how we talk about some of the events that our trainees are experiencing. That'll move us into our first breakout with the emphasis of talking about events that you've experienced or been aware of or know of at your own institution. Then we'll move on to having Michael Gibson talking about addressing harassment and discrimination as a program director, and then talking a little bit about institutional measures before we go on and have a case-based discussion in the second breakout group. With that, I'll start off with discussing the first case. Adrienne Adams, who is the program director, as Sarah was mentioning, for the Child and Adolescent Psychiatry Fellowship at Rush Medical Center, will be joining us as well shortly to discuss the remainder of the cases. So just to begin, this case was, again, all of the cases that you're going to hear about today in the presentation were cases that actually occurred. Everything all in this first set of cases that we're going to talk about, as well as the cases at the end, are ones that we have brought forward and have been a part of in some way. So in this first case, while completing your rotation during the third year of medical school, you along with your co-students are all dressed in short white coats and are milling around waiting for your attending to present. An older white male patient walks from his room, passing a few of your co-students, stops directly in front of you and tells you, "I need you to go change my bedpan." Everyone hears the patient, but no one says anything to correct the patient except for you. You tell the patient that all of you are medical students. So why did he walk over to you and ask, and why didn't he ask for a nurse? So you'll see during, when we talk a little bit more about the prevalence of these events that occur, that sometimes these events are include microaggressions, and we'll be talking about the definition of microaggressions. Oftentimes, students and residents are experiencing these events in the context of an audience, right? So you can see here that even though everyone experienced this patient walking up to this individual and asking them specifically, and in this was a medical student of color, no one addressed the patient. No one felt comfortable saying anything or knew what to say. And in that, the minority trainee is left with both trying to figure out what to do while having an entire group of people watching them. So you can imagine the complexity of that situation, both in dealing with a situation that is not explicitly one that is overtly racist, but we know is based in the idea that that trainee is a minority. And so this is a situation that what you will hear and see in the literature is one that is not uncommon. Case 2. In your OB-GYN rotation as a medical student, you and your classmates meet with the residents to discuss the clinical practice of the GYN clinic. And then the residents each pick a student to work with to see patients. No one picks you or even looks your way. You then ask the attending, who should you work with? And are told you could work by yourself or precept alone. For those of us who are physicians of color, this is not an uncommon experience. And though this case example that's written here did not occur to me specifically, I can tell you that I have been in many situations where this was the case, where it was clear that all of my non-minority classmates either paired up with each other.
Sarah, I'm here.
Adrian,
Sorry.
you're on? Great.
I'm so sorry. Time
No
change.
worries.
My bad.
So
Yeah.
we're on the second case.
Okay. Yep. Second case. So I think you were just discussing the yeah. So basically this did happen to a woman of color as a medical student again. And as Sarah stated, she was doing the OBGYN rotation, which was of particular interest to her at the time, and that it was in a hospital setting, but also located within a community. So there were a lot of females coming from various, from an urban area, as well as surrounding suburbs. At the time, you know, one of the early rotations, she along with her classmates were able to meet with the residents, and it was at that point that the proctor would kind of discuss the clinical practice, what were the expectations for students, at which point then the residents then paired up with medical students. As she watched people being paired up, she realized that no one was even looking her way and no one paired up with her. There was even at one point, I think, a trio of people, but still no one suggested that she join them or pair up. So at that point, the female of color, she then went to the attending saying who should she work with. And she was told that she should maybe just work, she should work by herself, but then she could staff with him one-on-one as she saw the patients by herself as a student. So once again, it kind of leaves this person feeling like an outsider maybe, or even what we hear about imposter syndrome, and that people don't feel that maybe she's really a student like all the other students or as good as other people. And, you know, at that point, there was probably no word that she could identify with it, but just maybe she just it made her feel bad and very uncomfortable. Did you want me to go to the next slide, or because we're going to talk about them later, Sarah, or do you want me to see if there are any thoughts?
I think we can continue to move through the cases.
Okay. Let's see. There we go. Okay. So at this point, this is another female, and these are all true stories. Female of color. She's an intern at this point, so made it through medical school. She's on her second week on the medical floor. And, you know, at that point, everyone's excited about being a doctor finally. So she's established a pretty good bond with her team. Out of the team, there's of course the senior, the two residents, another co-intern, fourth-year medical student of various ethnicities, Caucasian, maybe some Middle Eastern, Indian, and another African-American female who's the medical student. So while sitting in the room with the sub-I student who's African-American as well, and the co-intern who was born in the US but of Middle Eastern descent, you're asked, when do you talk jive? And I realized that a lot of millennials have no idea what jive means. So I'm going to just kind of, jive is slang. And really, I don't know who used it, because to be honest, I've never used jive. But if you ever watched the movie Airplane, they talk about, and that's a comedy, they talk about jive as far as being a Black or urban slang. So she was asked, do you and your friends or do your family talk jive at home? Like, when do you talk it? Because I never hear you speaking jive when you're here at work. At that point, I would say the intern and the African-American student both looked at each other, and then they laughed, but and it was more of an uncomfortable laugh, like, wow, but I think they felt more because they were friends with this person to actually explain that, you know, people don't necessarily speak jive. It all depends on where you're growing up or who you are as a person. And so there are just some African American people or people of color that, yeah, we just speak English like everyone else. So it was uncomfortable, but then it was also funny to even be asked that at the time. But I realized in retrospect that once again that this is something that happens frequently to people, as far as even President Obama, when he was running, you know, he was told that he speaks very well for a Black man. So I think, you know, we've seen even as recent as, what was that, 2008? So frequently, I think for people, if they're people of color, if they're successful, at times there's this thought that, but what do you really do when you're behind closed doors? Next slide. Case 4. This is another female of color, a third-year resident at this point. She's in the outpatient setting, meeting with a new patient. She just kind of introduced herself. She's wearing her white coat. And the patient very directly states, like, you know, you seem like a nice person, but I want a white doctor because I think they're better. And kind of demanded that you go get the supervisor so that you could change doctors. That's, of course, more overt racism there. I think there's no misunderstandings of what that would mean for a person of color. But once again, I think it reinforces that thought of imposter syndrome that a lot of people of color sometimes feel. Next slide. And then case 5. So this is a female of color. She's an early career at an academic facility. She's an outpatient medical director and a fellowship director. She realizes at some point, you know, early on that both the adult training director, the adult outpatient medical director, the med psych training director, along with the chairman of the department, all attend leadership meetings. And by the way, all of those positions at the time were all older Caucasian males. And during these leadership meetings, departmental changes and updates are discussed. But although you retain roles for both of those in child psychiatry, you were never informed or invited to attend that meeting. And you only heard about the meeting from a new business administrator who asked, how come you weren't there at the meeting? So once again, that's kind of along feeling like that you're not part of the group, your opinions aren't valued, and yeah, I think reinforcing possible imposter syndrome. So, you know, these situations do happen. I think a lot of times as an African-American female, and I will say that these are actually my experiences, so they're all true. As an African-American female, I think working in an academic facility, you often feel as if you're not part of the group, and oftentimes you might be the only person of color in the room. And often sitting there, you might be ignored unless you're able to be more vocal, but then of course you run the risk of being told that you're being too direct, which I think is part of being a female, that if you're more outspoken, then you're direct, but if you do that as a white male, then you're just being a leader. Oh, so I guess next slide, Sarah, or I think I'm done for this part, right?
I think you didn't discuss this one yet about, oh, you did, okay. So thank you for sharing those, Adrian. I think it's really powerful to hear that, you know, for Adrian herself, who, you know, talking about situations that have come up at every step or phase, both as a medical student, as a trainee, as an early career faculty member, and as a faculty member who holds multiple titles and roles, and thinking through the way that discrimination or implicit comments or explicit comments occur throughout someone's medical career, and what the emotional toll and burden of that is as individuals continue to experience it over time. I will be presenting this next section, talking a little bit about understanding the prevalence of which harassment and discrimination and mistreatment occurs. Before we do that, we wanted to poll the audience and understand from you guys what your own experiences are. And so we have right now a series of poll questions. The first one is, have you ever experienced discrimination or harassment by a patient or family member? So I'll give you guys another couple seconds to respond. You just have to click, for those of you guys who are not familiar, you'll have to click on with your cursor either of the buttons. So it looks like we had the majority of respondents, and you can see here about 70% have experienced harassment by a patient or a family member, or a patient's family. Next question. Have you ever experienced discrimination or harassment by a staff member? All right, so it looks here like this one is more split in contrast to what we saw with the poll results. So you can see about 56% of you said yes, that if you've experienced discrimination or harassment by a staff member, 44% saying no. Next question. Have you experienced discrimination or harassment by another physician? All right, I think we can go ahead and share the results. And you can see here, even more so than in the other questions of patients or staff members, that this is the experience that is more common, and that is actually what we know from the literature as well. Next question. How many incidents of discrimination or harassment of your trainees have you been made aware of in the last 3 years? And we can go ahead and share those results. And it looks like most have experienced 1 or 2 incidents, with a minority at 8% having none, and 11% having 5 or more. Next question. Which types of discrimination or harassment have your trainees faced? Explicit refusal of care, explicit gender, age, racial, ethnic remarks, questioning their role, nonverbal disrespect, discriminatory jokes, or assertive inquiry into their background. All right, we can share these results. So you can see explicit remarks about the trainee are the ones that we see the trainees facing the most, followed by questioning their role, and then followed by nonverbal disrespect. Now we can end that poll feature. So what we know from the literature, and so this study here was actually one that was conducted on WebMD, and so this included both physicians as well as other clinicians, but 59% of physicians had experienced biased or discriminatory remarks from patients, and the most common type was this request for transfer. So this is something that you see over and over in the literature, is both comments on an individual's status and then a request for a change in provider. So this was another study that was published in the Journal of Graduate Medical Education, looking at what types of discrimination and harassment are trainees facing. And so they include many of the same things that we just conducted in the poll, which is explicit review, going from the ones that are more explicit, so explicit refusal of care, explicit remarks, to ones that are less clear. So things that are put in the form of a joke, similar to the example that you heard Adrian mention before, assertive inquiry into one's background, or comments that are inappropriate. So what we know from the same study is that the trainees that were polled in the context of this study described significant emotional toll. They described increased emotional burden, withdrawal from participation in activities in the program, feeling as though they had decreased clinical learning, and feeling less accepted or part of the group. And for those individuals who were non-targeted bystanders, they experienced moral distress and uncertainty about how to respond. They also addressed barriers to response. And here you saw a number of interesting findings. So individuals reporting lack of having the skills of knowing how to respond, a perception that if they did respond, that nothing would happen, fears of looking unprofessional, and uncertainty about who within a clinical care team should respond. Is it the person who's the most senior? Does that person respond? Is it the person who the comments were addressed towards? Or are they the bystanders who are part of the experience? And that uncertainty led to these feelings of moral distress and increased emotional burden. Looking at discrimination overall towards trainees, what we know from a meta-analysis conducted by Finesse in 2014 was that up to 60% of trainees describe discrimination, and this meta-analysis actually included both residents and medical students, as well as 35% looking in the breakdown of different medical subspecialists. So for up to 45% actually of family medicine docs, family medicine trainees reported discrimination or harassment of some kind. 35% was from patients specifically. Out of that, about 27% experienced discrimination or harassment specifically based on gender, and about 25% experienced discrimination or harassment based on race or ethnicity. Interestingly, in this study, what they found was that verbal comments or verbal inquiries into care were the most common. even though I described here that 35% occurred by patients, what we found in each of these studies was the most common perpetrator of discrimination or harassment were other physicians. And that is a consistent finding across all of the literature. So in terms of the study looking at emergency medicine trainees, what we saw was that 16% were sexual harassment or sexual comments, and 25% being racial or ethnic. In the study conducted by Whitgob on pediatric residents, what you saw was that about 15% of them have experienced discrimination and harassment. Out of that 15%, the majority, or 67%, was discriminatory comments that occurred by patients or families. And in that context, about 50% of them didn't know how to respond, and about 25% of them believe that even if they did respond or told somebody about it, that no action would likely be taken. So in that meta-analysis that was conducted by Trainees in 2014, what you see is that verbal harassment is the most common, and that the most common perpetrators are consultants, though you see a sizable proportion talking about discrimination or harassment from patients in particular. And out of that meta-analysis, what they found was that in the studies that Trainees looked at, there was a number of studies that looked specifically at the increased prevalence of racial, ethnic, or cultural discrimination against non-white trainees. In this study it's called the Happy Doc study, it was actually looking at Canadian interns and residents after they've completed board examinations, and they looked at intimidation or harassment behaviors. What they found here, you can see that there's a sizable portion that experiences from patients, 45%. But one of the concerning things that you see that came out of this study, which actually has not been looked at in any other study, is that residents in other programs, other residents broadly, and residents in their own program, as well as the program director, were also groups with sizable minorities who were the perpetrators of intimidation or harassment towards residents. Interestingly, and we're in the process of actually gathering some of this data, there is no study looking right now at discrimination or harassment of psychiatric residents. What we do know is that there are a number of studies looking at patient-based mistreatment broadly. And this was the largest study of that kind that looked at, by DeVere from 2016, that looked at trainees from a representative sample, a nationally representative sample from a larger number of training programs, and looked at them across training years. And in this, you see verbal threats, unwanted sexual advances, and physical intimidation kind of rising to the top. So in psychiatry, I think there's been a lot of focus over the years, generally on safety and assaults by patients. Many of us include those trainings in our training programs, but very few have trainings on these more subtle forms of patient mistreatment that are occurring: verbal, physical intimidation, and sexual. And so that is really where we know there is a gap. And lastly, we know from a number of different studies what the common psychological consequences are. And now looking at increased interest on well-being in trainees, particularly now that this is included within our ACGME program requirements, we do know that mistreatment by patients as well as by others cause a decrease in well-being, as well as all of the pieces that you see mentioned here: guilt, PTSD, symptoms, anxiety, cynicism, exhaustion, self-doubt, and shame. The other interesting part that comes out of the literature is that, and that is the piece that Dr. Gibson is going to talk about next, is that reporting behaviors are limited. So rates of reporting of discrimination and harassment to authorities or program directors is actually uncommon. And the most common reason is because there's a lack of awareness about the centralized reporting process. And what you see is that most residents describe that this process doesn't even exist and that they wouldn't know who to go to. So for those of us who are training directors, I think for many of us, we think, well, why aren't they coming to us? And that leads to this other concerning finding, which is that trainees, residents in particular, are concerned about reprisal in the context of reporting. Would they seem more unprofessional? Will their evaluations be affected? Will their standing in the program be affected? And that these are often barriers to reporting. So before we move into the breakouts, where we're going to get a chance to have people talk about some of what they've experienced, I want to make sure that we are kind of all on the same page around terminology in discrimination and harassment towards trainees. And so Adrian is going to talk to us about this piece. Go ahead, Adrian.
Okay. Yeah, so just some important terms to know, and I guess regarding the issues. So we frequently hear the term microaggressions, right? Microaggressions first used around 1977, and I just realized it was initially coined by a professor or psychiatrist by the name of Dr. Chester Pierce at Harvard, who was African American. And also he was a consultant for Sesame Street, so some, I guess, trivia for you guys. But he's the first one that kind of termed, and he was a pioneer a lot in these studies, both for people of color as well as LGBTQ, as well as different issues. But microaggressions is typically the study for assessing the impact of subtle racial expressions and to gain an understanding of stigmatization and bias. So microaggressions typically are classified into three main types of racial bias. One of those would be microassaults, and typically microassaults are the more overt type of discrimination. These might be explicit racial, verbal, nonverbal behaviors, and these typically are intentionally meant to hurt that person. So things such as when we notice people hanging, oh my gosh, why am I forgetting the knot, the nooses, thank you. Hanging nooses around, or if we see people that might have spray painted a swastika on a garage or something, or so those are typically more micro assaults. Yeah, I agree, Judith. Not so micro. It's pretty blatant. So that's why those are typically the most things that you notice, and you can put a name to racism with those. Switch slide, Sarah. Whereas I would say the micro invalidations and micro insults typically might be harder to really say, realize that this is a form of discrimination. Typically as the person receiving these type of things, too much.
Sorry about that.
That's okay. Typically you feel like there was something done to you, but on the other hand, you can't always put a finger on it. So when you think about micro insults, that might be something where it's either verbal or nonverbal communications that kind of convey rudeness to you or insensitivity. Micro insult might be something like, as a person of color, if you're waiting in line to purchase something and then say a white or Caucasian person comes in front and then the salesperson helps that person instead of you, although you've been patiently waiting in line. So but frequently if called out, might be something like, oh, I didn't see you there. Micro invalidation, these are typically communications that exclude you, right? Or nullify your thoughts for feelings of a person of color. So that might be such as how I felt in one of my examples when I would sit in a meeting and people are kind of talking around me and I tried to voice an opinion and another person in the meeting talks right over me. Which once again, they could say, oh, I didn't know you were speaking, even though, yeah, I'm speaking. So that's more what you say invalidation, or something such as, and this is a frequent example, as an Asian American, if you happen to be standing there and someone's like, oh, what country are you from? And you could say, I'm from Sacramento. And then they'll say, but no, really, what country are you from? So it's that thought once again that you're an outsider. You really aren't American, or you're foreign American. So that would be more of an invalidation. Okay, Sarah, switch. And typically people kind of say, well, so what about microaggressions? Just kind of, you know, it's water, let it just wash off your back. It's just something little, let it go. But they've actually done studies showing that there are problems with the microaggressions. Typically they've studied and realized that people of color, the LGBTQ communities, often feel like they must represent their race, ethnicity, sexual identity in a positive way. So there's always this pressure to be the best, to outperform, to make sure that you're setting a good example. So frequently, and I have to say it, when there's something happening in the community, you often say, oh, was it a black person? Because once again, you know that you have to kind of try to offset whatever happened, even though there are multiple people of color, but still you feel like you have to show the example that not everyone's going to rob a store or something. Whereas if there's and they've shown this in a study as well, for say Caucasian people, typically if there's a person who they find out is a serial killer or something like that, they've shown that they don't really have the same feelings of, I have to show a good example. So they don't have that innate pressure because they realize people are individual. You know, I'm not responsible for what someone else is doing. Health risk. They've shown in a few studies, and this is in particular for African Americans, that we have higher rates of hypertension due to microaggressions. We typically have PTSD symptoms, higher rates of anxiety, depression, substance abuse. So it really affects many aspects of our well-being. Typically this internalization of others' negative opinions, and there's a perception of times of feeling like you can't control your own outcome, that the things are stacked against you no matter how hard you try. And they have shown in a few studies, and this is more particular a high school student study for poor academic performance, that they showed that if they told females that you're not going to perform as well in math, typically they do not perform as well in whatever type of math examination. And if they told people of color that, you know, you're just not as smart as, say, other people, typically in those exams, they showed that their scores were lower. So in a way, they were primed for failure, which, you know, once again, they've shown in studies that in high school settings, a lot of times people of color are kind of told, or were told, to go into other fields like trade and think less about going into the medical fields or science. Okay, Sarah. So the thing is, I always like to not hear everything doom and gloom, and I like to say, what can we do, right? How can we make this more positive? And I think one of the things that AdPERT's doing, which we're doing, is, you know, bringing it up. It's racism, discrimination are things that happen all the time, but unless we face it head on and figure out how we're going to combat it, it's not going to go away. So more case discussions, definitely having more implicit bias education, both within the department as well as institution. Preparing our trainees early on about racial, ethnic, gender discrimination, both for even their own implicit bias that they might have towards their patients. I remember in particular, we had a resident once who he had an African-American patient, and he really didn't expect this patient to ever go back to work or go to school. And I'm like, well, why not? And he really didn't have an answer except, he didn't have an answer. So I think there's that implicit bias that, you know, some people just aren't going to amount to things. So you really have to kind of work with the trainee to kind of say that everyone has opportunities and everyone can do things. As well as educate, you know, within the department, institutional policies regarding discrimination, and we need to make sure that everyone's aware of the chain of command for if things do escalate and how to fix things. Yep, that's it.
All right, great. So thank you, Adrian. That takes us to our first breakout groups. Um, you're going to go ahead and be placed into those groups now. For those of you guys who may have joined late, what Sarah had mentioned is some people will enter the breakout groups immediately. Others, there may be a little bit of a lag time, or it could look like your Zoom platform has turned off. So just be patient, and it could take up to 30 or 60 seconds to transition into a break room, but hopefully you should transition in fairly smoothly.
I am.
Can you scroll down here?
Mhm.
I gave everybody the ability to unmute themselves.
Actually, you muted everybody.
But I gave them the ability to unmute.
Okay.
Say something in the chat.
Why is Catherine not going anywhere? Wondering why it's so slow for her. I don't know how to manually move her. Are you having another problem?
Well, yeah, people have started to unmute themselves. I'm looking in the. Okay, so manually move who?
How do I manually move her? Because she's just not going at all.
Just click her. And
Okay,
move to.
I have to find her. Shoot.
This list here.
Catherine. Why would it just not move her? Unassigned. Oh. Assigned to 1. Assigned to 2. Assigned to 3. Assigned to 4. Ah!
In training, we're talking about African Americans or Hispanic. I think Spanish, my first language is Spanish. Yes, I was where I'm the program manager at the
Sorry about that. This is my first try with this. Okay.
I'm checking the phone that everybody's able to talk. So far, yes.
Being a physician and patients may have stuff in their
How can I go to a Berry Cover? I could just click join and go there.
Yeah.
Okay, I'm going to go to 1.
All right, everyone. I think we're back.
I'm not sure everybody else could see that warning coming. We got cut off. Sorry, Ashley, right in the middle of your comments.
You're like, that's enough from Ashley. We're done.
I saw the warning come up, but 15 seconds to go. I thought you guys could see that too. I don't know. Could you see that on the screen?
We did. I thought it said 5 seconds. So I was like, oh my God.
Okay, good.
I must have just been oblivious. I was in the.
I'll be more careful about that in the future.
Thanks for your patience, everyone, as we're figuring out this technology. I appreciate it.
So I don't know if anyone from the group wants to share anything before we move into Michael's section on what programs and institutions and program directors can do to address some of this. Maybe we'll take one comment, or if any of the group leaders want to add anything.
Okay. I'll just real quick, I guess, for my group. I thought we talked about some processes, and there's anonymous reportings and training in some institutions. And I thought one of the things that was brought up, we don't see or maybe hear much in programs, is the bystander training. Discussion, kind of a brief discussion about that, how we're sometimes really wired to just agree immediately. But calling out right away is really important as part of maybe showing some support. And of course, I think like everybody else in terms of support, EAP or outside resources, as well as just kind of sit down and process it with your residents.
All right, great. Thanks for sharing. So I am going to move on. We have a couple more poll questions, and then Dr. Gibson is going to get started. And in this next section, we're going to be talking more about interventions. So what are the things that people can do? So the first poll question is, have you ever personally intervened when discrimination or harassment of trainees has occurred? All right, we can go ahead and share those results. And it looks like the majority have, which is fantastic. The next question, do you feel comfortable intervening? And we can share those results. So it looks like the majority do, with some not. Next question, what are some of the barriers that you experience in intervening in these situations, whether you feel comfortable or not?
Oh, Sarah?
Yep.
I just want to say that I know that in one of the chats from before, Sheldon had mentioned that a lot of times residents in general have discrimination, I guess just for being a resident physician. So I kind of feel like this goes into this question, but yeah.
Yeah, I would agree. I saw that comment as well. And I appreciate that being brought up because that is also a consistent theme in the literature. And was mentioned actually several times in some of the family medicine studies that one of the reasons for discrimination from trainees was on like being a resident themselves and not having completed their training. So that certainly is one thing that's been brought up. And then there is another body of literature looking at, stigma with psychiatry, and then with psychiatry trainees in particular from other medical subspecialties. So all of those things are true. So we can share this poll. So what are some of the barriers that people are experiencing? Lack of awareness seems to be the most common. And it's that people are finding out about these events way after the fact. And so then it feels more challenging to intervene. And two last questions. One is, do you have a current process in place for when these events occur? We can go ahead and share this, I think. So many people are saying yes, they do, which is fantastic. And the last question. Do you have support structures in place to specifically address when trainees have experienced discrimination or harassment?
Oh, and Sarah, this is something in our group that was brought up as far as the culture of some of the residents might be delayed in telling the program director about issues because they don't want to feel like they're being tattletales, and how to address that culture as well.
Mm-hmm. Yeah, it's a great point. All right, so that takes us to the end of the polls. And then we'll move on to Dr. Gibson's section on addressing this as program directors.
And Sarah, in the interest of time, I think we'll just hit all the bullet points as soon as we go to that slide. So let's go to the next one. First thing we got to do if we're going to address this is have some ground rules in place, let people know what is and is not appropriate, particularly if we're talking about patients and how patients act and our patients, but we have to take into account the clinical context. Certainly, I'm going to respond differently. If a patient comes in an acute manic episode and is doing things that are floridly inappropriate, I tend to just crank up the dose of medication rather than going to some sort of administrative process. It becomes more ambiguous if the patient has a severe personality disorder as to whether a behavioral intervention may actually be therapeutically appropriate. And then I take a whole different stance if it's the family that is involved, and have a very low threshold. We have explicit statements within our medical center about expectations of patients and an expectation of non-discriminatory behavior by patients. And that allows us then to step in and call people out on things. But the ground rules have to be laid out there. The residents need to know that. And constructive ways of responding. Confrontation is not even usually the best way of responding. And we had a great session a few months ago where a group of actors came in and did a whole series of responses to inappropriate behavior that didn't quite reach the level of a formal administrative response, and all kinds of different options for how to respond to that. That was a very powerful experience, very useful experience. Next. And so we also need to have in place and make sure the residents know we have in place avenues for reporting. And multiple avenues usually work better than single avenues. Building a relationship with chief residents, or chief residents building relationships with all the residents, senior residents, attendings and supervisors, although maybe involved in this sort of behavior themselves. We certainly hope not, but if it's about addressing things coming from patients and families, Those would be the most intuitively obvious people to turn to. Program director, certainly I want to hear about things, but it depends on what level it reaches. Next. And so what kind of interventions are going to be in place? What can we do when we receive reports of mistreatment? One of the first things is to have a debriefing with the resident, find out exactly what happened from a quality improvement standpoint, find out what happened, but also offer support and assess the situation of how you're going to best be able to intervene with that resident to make sure that they are comfortable moving forward, that they know that you're on their side and you've got their back moving forward. And that may give you some hints as to where else you should be looking, as to how prevalent some of these things are. And always take each of these events as an opportunity to look at the system as a whole and see what else might need to be done, okay? Now, if there's an immediate intervention that's going to be required with a patient or a family, figure out who's going to do it, who's the most appropriate person to do it. Usually that's going to, depending on the severity and the nature of it, but usually if the person who's closest to the incident can respond, that has the most educational merit and in most situations is going to be most appropriate. But really think through and have a fairly low threshold for moving up the chain of command. You want someone who's, as with our treatment where we use the least restrictive environment and the least invasive therapies, we want the least threatening person who's going to get the response. You know, that might be you, but it might also be someone further down the line, a chief or a resident, senior resident, and so on, who would be able to do that. Next. What I call empowering the responder, that is telling somebody to do it. What do you want them to do? You want them to assess the situation, make sure you know what really happened, and the larger context, and discuss options for a response. The first thing you think of may not be the best thing, and having a group of people together to talk about what the response ought to be is something that we do in other clinical areas and would be appropriate here. But then also someone who's in charge of carrying out the plan and making sure it actually happens. Next. There we go. So you're going to flag times when there's units and services that need interventions, where there's a toxic environment someplace, or a single individual who seems to be getting more of these complaints than other people, where you're going to need to go in and do a more systematic intervention. And that can be behaving in inappropriate ways, encouraging that, or simply tolerating that, but it creates an environment that doesn't work. And I'm going to talk a little bit more about civility training in just a second. But then when we see persistent systematic problems, then it's really appropriate to move up the chain of command. Generally, you'll find that the folks who are higher up are going to be pretty aggressive about, pretty willing to move forward with this. We certainly hope that that's true. Okay, next. We had a civility training here earlier this year that got really good reviews from folks. We haven't done a follow-up to see how much change actually occurred. But we did it during grand rounds times. I know exactly who attended the grand rounds based on who reported among the faculty for CME. But it was very helpful to define incivility, to talk about what it is that we were looking at, and then also to have a goal in mind of building a community of connection. That's a phrase that we didn't coin, but is a powerful concept. And by the way, I see a comment here, who gave the grand rounds? I did, actually. I have the slides. Send me a note and I'll get them to you. So next. So here in the statement on civility that's in our institution came from one of our administrators, Lori O'Jack, who gave me permission to share it. I think you jumped ahead. I think we need to go back. Oh, okay. Yeah, there we go. That was right. Okay. So 4 points. Number 1 is to choose kindness, especially in tone. Affect really matters. And we above all know that. And always treating others with consideration and respect, and make that our default. Thinking the best. We work at this in our team meetings when talking about patients who were, annoying us. This is the best they can do right now. We'll help them do better, but this is the best they can do. Assume that everybody is trying to do the right thing. And you'll be right most of the time. Next. Then act in a supportive way. Encourage one another, acknowledge contributions, lots of positive comments, and then finally practice forgiveness. Choose a forgiving attitude and be willing, when folks are willing to make a change, to move beyond that. And then you yourself apologize for things. And with that, I'll pass it along.
All right. Thank you, Michael. So, as you heard Michael talking about, you're really looking for targeting intervention across multiple different levels, individual clinical faculty, the program, and the larger system. So I know we only have a couple more minutes. I want to briefly share with you some interventions and approaches that have been talked about in the literature. The first one was by Dr. Shankar out at the University of Washington, again, highlighting many of the things that Dr. Gibson said already. So before the encounter, setting the stage, understanding that these events are going to occur, asking the resident who may want to intervene during the context of an episode, just like Dr. Gibson was talking about, and then making the plan explicit. Maybe the team wants you to step in. Maybe the team or the resident or the students want to trial stepping in on their own, or using a model that we use in medicine, like you watch me as an attending intervene the first time, and then maybe you want to handle intervening if it happens to a student. And then having everybody commit to being on the same page. Second, during the encounter, reflecting in action, and I talked a little bit about this in the small group. Once you know that the patient is clinically stable, and Michael reflected on it, address it in the moment. Name the behavior as inappropriate. I'm surprised you would make that comment, or, if people are making like sexual or gender-based comments, I think you're trying to compliment me, but we're trying to focus on your health. Re-educating people on roles, or even if it gets to that level, removing learners from the setting. This isn't working. We're going to come back in 30 minutes and hope that you're ready to focus on your health. After the encounter, as Dr. Gibson was saying, reflecting on the actions, checking in, attending to people's safety, acknowledging what went well, and discussing what could go better in the future. There is a program that was discussed by Goldenberg and his team, which is called ERASE, a framework for helping faculty manage mistreatment, covering the exact same topics, expecting that it's going to occur, recognizing when it does occur, addressing it in real time, and supporting the learner and working on culture. So in terms of larger systems, like Dr. Gibson mentioned, it's important that you have key individuals involved and health system policies and procedures in place. So at the University of Michigan, I was able to consult on the policy that they developed last year, about a year and a half ago now, which was actually added to the patient rights and responsibility signage throughout the health system. So here you can see that Michigan Medicine is a diverse place, endorses a culture of diversity and inclusion, and that there is no tolerance for harassment or discrimination based on race, sex, gender identity, gender expression, color, religion, etc. And that behavioral violation of this policy by patients will be addressed as soon as possible. and no faculty, staff, or learner should have to tolerate a situation in which they're abused, harassed, or discriminated against. And then in addition to the program level reporting that Dr. Gibson talked about, that those things should be reported to a manager, and that there is an Office of Institutional Equity that exists that logs these and helps programs and institutions address them if they appear to be more systematic. So you can see here in general that the idea is this concept of prevention, readiness, and the ability to respond. And it requires that 3-level intervention, that you're establishing a commitment to a culture change, that you're training a team to respond so they're ready, and that people know how to respond in the moment and know how to debrief, and that there's a support structure in place. So I think that puts us a little bit over time. We're out of time for the second breakout group with case discussions, but those will be shared with all of you. And thank you to everybody for attending.
Thank you, Sarah, Michael, and Adrian. We definitely appreciate your participation. I think that if you have further questions, what we will do is we will share email addresses and ask that you respond there, but we will be sharing the documents and the PowerPoint and the recording. So everybody have a great weekend.
Thanks.